Continue to put a question answer session. So Dr. Mrinalini, it is over to you. Kindly start.
Okay, thank you, ma'am, and really thankful to the organizer team, full team actually. So let's start the presentation without any formal things further. And if anything anything is problematic, please interrupt me, ma'am, anywhere.
Sure.
So let's start. A very good morning to all of the resident friends. And obviously I just want to not to do in the traditional fashion, but I just want to be more sort of things like whatever is I feel most important into the practical day-to-day planning part of these patients. Okay, rest we all have the textbook and etc. Feel free to ask any question and any comment, please. It's my request, humble request to all of the residents. So my topic is radiotherapy in carcinoma larynx and hypopharynx. So first thing is why we have to take together the larynx and hypopharynx. And answer is in the anatomy, but we will come on that slide just 30 seconds back. First, probably we all want to know why, and then we have to use the radiotherapy. So in my view, if I left the palliation behind right now and just take the two things, that is the definitive radiotherapy. So definitely we need cure, locoregional control in the patient having disease, that is the one motto, and another is to give the adjuvant radiotherapy after the radical surgery to decrease the chances of locoregional failures. Okay, so how we have to do this radiotherapy? So various things are in it, that is what are the doses, what are the volumes, what are the field borders or segmentation in the advanced techniques, fractionation schedule, and probably a little bit about the chemotherapy regarding to the context of radiation, concurrent or neoadjuvant only. But I really want to highlight the two things else in this site. That is the precautions, limiting factors and sequelae, and it is the edema part, laryngeal edema, and sometimes it is up to the life-threatening conditions, and we need tracheostomy even in the later part of the life when patients really don't have any disease, but it is very, very symptomatic just because of the laryngeal edema. And personally, actually, I have encountered one of such of the patient in my follow-up. So that's why probably I am more keen to say here these things. Second, very much important thing after laryngeal edema is aspirations. And it is really important cause up to the fatal pneumonia in this patient. I mean, we are really wondering, patient doesn't have disease, patient doesn't have any symptom, but why still patient is dying? Like, I mean, why pneumonia is the fatal thing? So most of the time, or even in 1/3 to 2/3 patient, it sometimes is aspirations, and most of the time these are the silent aspirations. Okay. So purpose of radiotherapy in larynx and hypopharynx. In my understanding, it is the organ function preservation. To preserve the functions, that is the swallowing, speech, and definitely the breathing, but most of the time we embark on the swallowing and speech. One thing I want to highlight again, that organ function preservation is not equal to anatomical preservation. So we will definitely see these things again and again in my presentation. So so I just want to put few slides on the staging and why it is important, why okay, fine, we get a patient and we want to treat the radiation, we understand why we have to give, when we have to give, how we have to, but why we need to staging? Even in MD exam, it is like that, please memorize it. First thing is to diagnose we done the test to diagnose, then second thing is to get the staging. So staging is important because we want to give an appropriate treatment, neither the under treat, neither over treatment. Okay. So just few slides and few very important, or just highlights, not the very much in the detail. So this is for the hypopharynx, and we are very much comfortable with 2 centimeter, 4 centimeter, more than 4. 1 to 3 stages. But other than sizes, one important thing is key T2 is without fixation of hemilarynx, while T3 is fixation of hemilarynx, and it is going into the same fashion that T3 is fixation of hemilarynx. Hypopharynx has a peculiar thing, that is the extension to esophagus, and it is peculiar because of the anatomy. I mean, hypopharynx, we all know it is just as the continuation of esophagus further, so it comes into the T3. So please try to remember it. T4 is same. T4A is cartilage, staph muscle, the same, very much same in hypopharynx and larynx. And T4B is again same. I mean, it is. I hope it is very very easy to remember. Ancosis, carotid fascia, prevertebral, and blah blah. So next is glottic, and important for our exam point of also. So T1 is very clear. T2 is very clear. One vocal cord, both vocal cords. Then T2. T2 is with impaired vocal cord mobility, but not fixation. And fixation again comes into the T3. Okay. Another important thing which I want to highlight, that is the cartilage invasion. It comes into both T3 and T4. In T3, it is only the inner cortex. Okay. But in T4, it is the outer cortex. I mean, disease is now moving more out and involving outer cortex of thyroid cartilage. So basic difference between T3 and T4. And why I want to highlight the difference T3, T4, we will see further in the part of treatment. Okay. And I just picked this one photo from the AJCC 8th book soft copy to highlight that there are very nice diagrams in that book. You can just reference these nice diagrams from that book. Very much clearly seen that it is here the involvement of the thyroid cartilage here and involvement of the cricoid cartilage here. No more pictures from that. Supraglottic, again, important thing is in T3, again, the fixation. I want to highlight it further. Another important thing I want to highlight the spaces. Okay. Because pre-epiglottic space, para-epiglottic, these spaces are very important in the staging treatment part and when we choose the modality, because these are little bit, I mean, towards the poor prognosis. Okay. Then T4A is same, but what I highlighted previous, that outer cortex. Okay. And inner is again T3. This is very much same, nothing change here. Ditto for the subglottis. So after finishing the very short of this staging, I just want to highlight again the second thing, that is anatomy, applied anatomy. And why anatomy is important? Obviously, when we do the 2D plannings, we have to put the field borders, and we are very comfortable to see the bony anatomy. C2 से C6 तक we have to take, या from hyoid to cricoid cartilage we have to take, because that is the anatomical compartment. Okay, that is the anatomical compartment of laryngopharynx. We are very comfortable for the 2D bony anatomy. But why, as time passes and we are moving towards conformal techniques, okay, so now our responsibility is increasing. Our eyes need to be more tuned to see not only the 2D anatomy, 3D anatomy, I mean, more towards the soft tissue anatomy, like CT scans, MRI images. So it is very important to brush this part again when we are going towards the radiation part. Okay. So, I mean, the question comes in mind that we can see abnormalities in imaging very easily. Okay, that much, very much fine. We can see the abnormalities. Even radiologists can very easily see. That's fine. That's easy. But what is more difficult, that is the CTV. CTV, how much we have to give expansion. For that, we really need a good knowledge of anatomy. Okay, especially I have highlighted in my previous slide, that is the various spaces. Okay, so we move forward and just see the little bit very basic important slides of showing some anatomy. Like this is the hyoid bone, thyroid cartilage, and backside of thyroid and cricoid. We all are aware. We have, I mean, we just read it from the first prof. And this is the arabiotic fold. And when we just use our borders and we count the vertebrae, okay, it is T2 and it is T4 and it is T6. So 2, 4, 6 is very important because these are in the relation of these cartilages and this anatomical compartment. Again, showing the same sagittal sections and vallecula and in the relation of oropharynx and the laryngopharynx. I guess I really like this picture. I took it from the parades only, and actually I was confused in my MD time, and it's very difficult to make a clear image of this structure. So I want to little bit give some time on this image. So if we take any tube and we just make a cut over here and we just open it, I mean from this side and from this side. So when we make a cut here, we open it from this side and this side. So now it is something like this. Okay. This is the cutting part, and now we can see the inner thing of this tube. And this is this diagram. Okay. They have very nicely cut this pharyngeal wall, posterior pharyngeal wall, and just open it. Okay. So that we can see the inside structure. I hope I am little bit clear on this part. And now we can see this is the epiglottis, and these are the various cartilages, corniculate, cuneiform, and arytenoid, and posterior pharyngeal wall, lateral pharyngeal wall, and uvula. So, I mean, my purpose is not to say every single structure of this, but I just want to refer you this picture that please go and see from your pares. That is the very first picture of this chapter. I guess this is also a very important diagram to understand that it is a surgical specimen, and I guess surgeons are really more tuned, I mean, towards the anatomy in comparison to us, because they can see the live images, okay, in the patients. So this is again showing the same thing, and I want to highlight here the pyriform sinuses. Okay, so it is the same. We have cut open from the posterior end and open it. Okay, so if we take these two things and unite it, then it will make a posterior pharyngeal wall, and these are the pyriform sinuses. These are free spaces actually. This is so just this pyriform sinuses again here, and this is the cricopharynx, esophagus. From the back side actually we are seeing. Okay, that's all on this slide. So as I earlier mentioned that spaces are very important, so I took representative photos of CT anatomy, that pre-epiglottic space, paraglottic space, and again same paraglottic space here. And why these spaces are important, I already mentioned that as these spaces are involved, the stage is one step higher, that it becomes T3. So all spaces make T3. Okay, one step higher. That's why it is important. And these are little bit towards the poor prognosis, also. So after completing the applied anatomy, I just say that even in physiology or physiopathology, I mean, just 2 lines, that obviously life is important. That's why we are doing everything in the medicine. But after once we get, okay, now okay, we can cure this patient. And second important thing is quality of life. And probably you will see this word many times in my presentation. Sorry for that. But I just want to keep iterating this thing that quality of life is very much important once we secure the life. And that's why it is connecting here with the functional preservation, cosmetic. Obviously, cosmesis is not coming in this section, but least toxicity, as I already mentioned about the aspiration and the edema part. Okay. And even on all of these, we will see in the further slides that how we take decision. In this patient, we will go for radiation. In this patient, we will go for surgery. Sometimes in larynx and hypopharynx patient, these are the treatment modality deciding factors as well. That's why I put this sentence, this slide here. So after finishing it, now we come to the medicine. Why I write actually medicine here? Because obviously we are talking about radiotherapy and definitely about chemotherapy also a little bit. But please remember, this is a part of medicine. Don't forget patient. Don't forget about electrolyte disbalances or, I mean, those things which are definitely we have to deal during radiation or during concurrent chemo radiation. Please don't forget that, just to highlight this. I will come on this slide after some time, and please, and I just want to finish some small things first. That is the surgery part. Just this slide, that okay, why we always highlight the surgery, because obviously it is the oldest anti-aging. Okay, just do the surgery and finish this. Okay, just take care of the patient. Another thing is जो अभी भी important है, that is the life-saving thing, that is the tracheostomy, and we can't deny that. Okay, obviously important thing is low-lying tracheostomy in these patients. And nowadays surgery as a primary modality to get a good survival is reserved for as a total laryngectomy reserved for T4A disease, or second group is extensive or unfit or unfavorable T3s. This is this is a debatable thing. Unfavorable T3s, whether we have to give a chance to organ preserve or we have to directly go for total laryngectomy. I mean radical surgery, but it is a debatable kind of thing. Some people say why you have to, I mean, it is a poor thing. It is a poor prognosis factor. Why you have to give time and just do the salvage things on the surgery. When you salvage things as a surgery, directly go and do the total laryngectomy. But some people still say, okay, you can take a chance to organ preserve. But okay, that's fine. And obviously with the post-op party. And in another thing about surgery is that the partial laryngectomies, that is the organ function preserving laryngectomies, either vertical or horizontal, that is for the T1 and T2, that is the early disease. Okay, these are organ function preserving surgeries. That's all about surgery. I mean, you can say this is a very odd slide. Why you put it? Okay, this is odd slide, but probably I mean, my mind is more tuned towards the integrated therapies in the medical colleges, so that's why I put this name. Why? And I mean, I really want to highlight the one thing, that is the rehabilitation. That once you treat the patient, please don't forget the rehabilitation of the patient. And sometimes we feel okay, ठीक है, अभी आप जिंदा तो हो, ठीक है, नहीं बोल पा रहे हो तो क्या है, आप लिख लो, आप राइस ट्यूब से खा लो. I mean, please don't say that. Please don't say that, and even just try to do a good rehabilitation. Okay, you can say कि कॉलेज में तो आप अभी 3D पे ही नहीं पहुंचे, या I mean, you are not doing even IMRTs. How can you say, how can you embark on rehabilitation? It is like that कि you are doing daydreaming. Okay, fine, I am doing daydreaming, but obviously if we see the dream, then probably someday we or our next generation can fulfill these dreams. But please, at least we can say, okay, we can do something about the rehabilitation, and we are not going to forget it after finishing the treatment and getting cure to the patient. Again, quality of life and sequelae, like I mentioned, aspirations, fetal pneumonia, very much known for the pharyngeal malignancies, because we know nowadays IMRTs are going towards the DARS preserving IMRTs, and various studies already are there from last 10 years. Now more are coming up, and even in MDTs people are doing it. So why we want to preserve DARS? Just because for the aspiration. So when we are preserving the DARS, that is pharyngeal muscles, but I mean, we are talking about pharyngeal malignancies. So it's very easy to understand why these patients are more prone towards the aspirations. Okay, please don't forget just one sentence to the patient कि बाबा अभी treatment हो गया, आप ठीक हो गए, then please don't start smoking again, because obviously it is important for recurrence. But I haven't put recurrence here because I mean, we already know it. That is in our mind. That is already imbibed. But why I want to highlight the second factor, that is a speech quality. Okay, edema part. So smoking is bad for that. Follow-up. So we are always crying for our follow-ups. Our lowest to follow-up is 60%, blah blah. So why we don't shake hands with the community people? I mean, again, the daydreaming, but probably yes. Don't forget on follow-up to see the symptoms, or probably symptoms related or examination part towards the second malignancy. Don't forget that, please. So I hope now we can come on to the major part of my presentation and the topic, that is the radiotherapy. Okay. So before going towards the field borders, I know okay, residents probably say कि madam is doing just this and don't showing us the field borders and delineation. I will show definitely in the later part, but first we will finish the idhar udhar ki baat. Okay, so if we say ki what we get from the Western world, because I always we always found for that. So first we will see what Europe people or UK people say about the treatment part of these malignancies. So it is for my resident friends that, okay, I have taken snapshots of this very beautiful paper and guideline probably say, this is from the ESMO guidelines 2020 October. So probably you can say this is the last year updated most recent guideline from the ESMO. Very beautiful, 10, 12, 15 pages, and please go through it yourself, discuss it among selves, and you will be very much, I guess, wiser, or I mean, your understanding is very much increased. I will just take the few snapshots, which I feel I have to give importance, highlights for in the respect of these malignancies. Obviously, this is for all, but I obviously choose larynx and hypopharynx important points from this guideline. Okay. So I just witnessed that most of the time when there are case presentation, we just confuse why either we have to finish with chest X-ray or we have to go for chest CT. So this guideline says very clearly as a minimum chest CT, especially in the patients where there are high risk. High risk means heavy nodal burden and T4s. And definitely, if you are choosing a radical treatment, then itna to banta hai ki you have to rule out those 15% or 15% probably, more in the hypopharynx like 20% to rule out the metastatic disease. Please, I mean, now it is coming to the guidelines, no more X-ray business. Logistics, financial, that is a separate story, but guideline says this, okay? And in the workup staging, I just again, I mean, I want to highlight one thing, chest CT already mentioned, and speech swallowing function. Don't forget nutritional status, weight assessment, and social psychological evaluation. That is the second part, obviously, sorry. First part is very much what we know, ki staging, diagnosis, blood test, dental examination important. Definitely we have to do, but the second part is also very important. If you want to finish the treatment in time, if you want to cure your patient with maintaining quality of life, then this second part is very important. This is the complementary thing. Okay. Okay. What I want to tell you in this slide, probably again giving the weightage to my choice of this second part, that is the patient parameters. Please don't forget patient parameters. Don't make decision of treatment only T1, T2, T3, 4 or N1, N2, N3, 4 or N1. Please don't. And please just encompass the patient parameters also. Don't forget to include patient parameters whenever you are going to decide about radical treatment, palliative treatment, whatever. But I mean, maybe it is 30%, 35%, and 65% is your T and I mean, disease related, but 30% is also a good percentage. Same thing, nutritional comorbidities, especially diabetes, CVAs, cardiopulmonary, renal function. Renal function to bhulna nahi hai because splitting is the drug, so please don't forget the renal function. Geriatric patient, special care, and psychological, social, dental status already, and rehabilitation again. Okay, weight loss. So I just highlight, and again I am highlighting because I guess this is also an important part. Nutritional values, treatment support. So when we are talking about MDT, we always remember surgeon must be there, radiologist must be there, madonc must be there, but radiologist must be there, nuclear medicine must be there, pathologist so definitely must be there, and don't forget the supportive things, nutritionists and research nurse. So probably, I mean, I'm also not, I'm not in the state to say, okay, we can have it, but psychologist. Okay. So again, highlighting the same point probably. In radiotherapy, I haven't covered anything about the proton because still it is in the trials kind of thing. I mean, not in the routine day-to-day practice. So I haven't covered proton here in this 1 hour. And about the early disease. So ESMO people very much clearly what we learned from our books, it is the same. In early disease, T1, T2 disease, N0, we have to do conservative surgeries. That is the organ function preservation surgeries. That is the minimal invasive surgical treatment, including laser microsurgeries. Only one thing on this slide. We can understand the philosophy of treatment in the larynx cancer from this picture, and again it is the same from this. So if we get patient with the disease of having the disease of T1 to T3, N0 to N1. Obviously, this whole slide is about M0, so I will not say again and again. This is M0 patients. So this is the early disease. Now, what we have to do early disease mein? We have to preserve the function. Okay. So we have two choices. Either we can go for radiotherapy, or we can go for conservative surgeries. That is the laser surgeries or partial laryngectomies. But probably laser surgeries are getting more weightage here. One thing is CRT, and that is only for the T3 disease. Okay. Up to T2, we have to finish only by the RT, single modality. If patient is having N2, N3 disease, and although there is no T3B, but this is the extensive T3, then treatment is CRT, and it is the level 1A evidence. We already know it. Okay. Another important thing, what I want to highlight here, that in many lectures, in many classes, we always discuss what role of neoadjuvant chemotherapy. So neoadjuvant chemotherapy has level 1A evidence only and only in the larynx preservation. And this is 1A. Okay, no more confusion about it. And they say, if total laryngectomy is necessary, then go for either go for concomitant CRT or use induction chemotherapy followed by RT, only RT, in case of complete or partial response after the induction chemotherapy. Or if there is no response, stable disease or maybe progressive disease, then go for surgery. I will repeat it again in the next slides. Okay, another option is surgery and lymph node dissection, but we will not go for that. See, T4A, I already highlighted in my staging slide that cartilage frank invasion, that is up to the outer cortex, is coming into the T4, otherwise in T3. For T4, direct, you have to go for surgery, that is the laryngectomy, obviously followed by the adjuvant RT. But still, there is a chance in few patients you can prefer CRT and maintain, just make the surgery, that is the total laryngectomy, just for the salvage. So that's why CRT and salvage surgery. But some people say no, directly go for the surgery, that is the total laryngectomy, because overall survival is little bit fair towards the upfront surgery. T4B, just one point, that T4B, okay, it's not for surgery. So either it can be for the induction chemo followed by RT, and obviously it will go with the response assessment, not without that. Or if your patient is very fit and you are very keen towards giving chances to the radical treatment, then go for CRT, concomitant CRT. But don't forget about palliative treatment, systemic chemotherapies, immunotherapies, and palliative RT, palliative chemo. And I'm more focused even towards the only best supportive care. When if your patient KPS is really 50, 60, then please don't think about any chance of radical intention and go towards palliative metronomics with best supportive care things. Okay. I hope I am clear here. One point I want to highlight it, that in T1, T2 glottic cancer, neither we go for neck dissection nor we are taking giving the this prophylactic irradiation to the neck, because T1, T2 glottic cancers are different. I mean very different in for the neck propensity. For T1, what I remember in my MD is 0%. For T2, it is a 2%. I mean, whatever it is, but it is less than 5% chance of having the nodal burden in T1, T2 glottic cancer. So no more neck business here. Okay. This is a hypopharyngeal cancer diagram, and it is the very much same. I mean, philosophy is very much same as for the larynx. So understand first one, and then you find it very easy to see the second malignancy, because these are like very much siblings type of things, because they are just on the just in the same anatomical compartment. Okay. So as we see there, T1, T2, early disease and zeros, larynx preserving surgeries. In hypopharynx also, we always say larynx preserving surgeries. So only RT or conservative surgeries. Finish. T1, T2, but N plus disease or T3 disease. CRT is the option. And induction chemo, again, I'm saying the same thing. Induction chemotherapy is the option. And if there is a good response, partial response, go for RT. And this is only RT, not CRT. Or no response, stable disease progression, then definitely go for the surgery. T4A disease, that is the frank cartilage invasion. That is the upfront surgeries you have to go. That is the radical surgeries. But yes, option is CRT with salvage surgery. But overall survival is better than, little better than upfront surgeries. T4B, same slide, same copy. Although I have, this is not copy paste, I have taken from the ASMA, but this is the same thing. So no reiteration here. So as I said about the induction, about the concurrent, from where this evidence came, I mean, this is level 1A evidence. So I have I just want to refer these this EORTC paper here. First, it was published in 1996 and 10-year update in 2012 Annals Oncology. And it says that at 10 years, there is no difference in overall survival or progression-free survival. That is 10-year overall survival is same, 13%, 13% in both arms. And what are these both arms? One is direct upfront surgery, followed by adjuvant radiotherapy with or without chemo. And second arm is give induction chemotherapy and just see the response. If there is a good response, there is a partial response, give another cycle. That is a total 3 cycles. And if, yes, after 3 cycles, you just go for radiation, radiotherapy, radical radiotherapy. And when there is no difference in OS, then you just preserve the larynx, maintain the quality of life of patient. And it actually allowed you more than half of the patient who are survivors, they retain their larynx. Okay. So overall OS is similar, whether you go for direct surgery followed by adjuvant RT, that is the standard arm. Comparison to the experimental arm, that is the induction chemotherapy. If it is the good response, complete response, partial response, complete 3 cycles, and then go for radical radiotherapy. So what is the benefit of this radiotherapy? That you can preserve the larynx and there is no decrease, no compromise in overall survival. And why it is? Because we have the salvage surgery with us. Okay. So I just want to refer this paper here. Another important paper that is for the laryngeal cancers. And veteran, this is very important paper, landmark paper, earliest paper, NEJM 1991, they also said same. Ki, at 2 years, you can preserve larynx in 2/3 of the patient. And obviously same, there is same OS. No compromise in survival, but additionally bonus is you can preserve the larynx and you can preserve it in even in 2/3 patient at 2 years. Okay, because 1/3 में तो recurrence आ गया, you have to go for salvage surgery. So 2/3 is a good number. So from veteran affairs paper and from the URTC paper, organ preservation approach with induction chemotherapy, I mean, it's completely settled with one evidence, no more confusion about it. Just to complete the series of 3 important papers, जो हमारे MD residents उसमें भी important है, वाइवा में, organ preservation approach में, one is veteran affair, second is URTC paper, and third is forestier. So veteran and this URTC, they are just about induction, but then forestier paper and this is about comparison of surgery followed by post-op RT plus minus जो standard था पहले versus induction chemotherapy followed by RT, obviously with good response. This is the important part, should not forget. And then they compare it with the CRT. Why we have to give induction? Just go with CRT, and actually in head and neck CRT, CRT is far better, and we are very much updated about it from the McKinsey paper. And they find that yes, CRT gives much better advantage than induction chemotherapy at 2 years for overall survival also and for preserving the larynx. Because after all, our main aim is preserving the larynx without compromising overall survival. But this is the 10 years update. Okay, and this is coming into this was there in 2013. This is a very important thing. Okay, fine, you can preserve more larynx in CRT, but one important term is laryngectomy free survival. And that is after, you just preserve the larynx, but what about the survival? After all, everything is for the patient, na? So they said at 10 years, whether induction chemotherapy or concomitant CRT, but your laryngectomy free survival is same. Okay. So that is the update of forestier, this RTOG 9111 paper, that LFS is same. So I have made my things clear. That's why I just want to I just told about the update first. This was the first result of this forestier paper. What I was talking, that it was best with the CRT, that is the 88% preservation of larynx, followed by induction, that is the 75%, followed by the only RT, that is the 70%. Okay, this was at the 2 years, but 10 years laryngectomy free survival was same. So I am not favoring induction chemotherapy. Why I am saying again and again ki 10 years ka update dekho. No, I am not towards induction chemotherapy. I am not biased towards induction. But actually, veteran paper and this URTC paper all are saying that there is nothing compromised about by the induction, at least in larynx preservation. So, अगर एग्जाम में पूछा जाता है इंडक्शन कीमोथेरेपी का एक एविडेंस बिना कंफ्यूजन के, that is the larynx preservation in advanced diseases, laryngopharynx disease. Okay. So I have taken more time here. So further, okay. So now reference business is finished, and we again coming back to our ESMO guidelines of 2020, and few important snapshots further about that CRT, what I already mentioned, and standard treatment in non-resectable patients, and is also indicating resectable patient when the anticipated functional outcome. Okay, what is this? Then T1, T2 में no confusion, organ preservation surgery or RT, no confusion. In T4A probably no confusion, upfront surgery, radical surgery. But T3 is a thing जिसमें पूरी कहानी है. तो T3 में you have to find the favorable ones, go for organ preservation. If these are unfavorable, or हम कर क्यों रहे हैं organ preservation? Because to preserve the functions, speech है, swallowing है, तो अगर वही compromise है baseline पे, and we say कि whatever we are going to do, disease will cure everything, but function will not come back. That means functional outcome is poor. Prognosis is poor. These are very extensive T3s, and we say कि नहीं, यहाँ पे there are more chances of recurrence. Then please don't do lalach and just go for direct surgeries, okay, rather than organ preservation. So T3 is some kind of debatable thing. And here patient selection is very, very important. It's the same already mentioned. Induction chemotherapy, I have taken already much time. Neck dissection, this is not related to hypopharynx and larynx, but this is overall in head and neck. But I found it important for the question answer viva for the residents. If you have done CRT for node positive patient and you have confusion कि now what I have to do, अभी आपको थोड़ा सा remaining लग रहा है या what, after the finishing the radiation, then please wait for 12 weeks, get done a PET CT, and if it is positive, then only go for the salvage neck dissection. Otherwise, just keep patient on follow. This is very important point. That's why I just mentioned here. Post-op CRT, we all know it very well. What are the indications? Positive margins, closed margins, PNI, LVI, and more than one lymph node, ENA. It's just revision kind of things. Doses again, 63 to 64 gray for the high risk, if having the high risk factor, and otherwise 60 gray standard. And RT we can omit in N1 patient, that is only if one node positive, but if dissected lymph node number is 15, that is adequate lymph node dissection. Little bit debatable kind, so I will not go into the detail of this. Okay, so just another important practical point, that is अगर patient आपके पास surgery करके आ गया, T4A था, surgery हो गया, then you have to give the post-op radiotherapy with or without chemo. So most of the time in medical college, at least in my medical college, that is a problem कि patient का surgery हुआ, 2 महीने patient surgery के पास रहा, after 2 months, in 3rd month suddenly they just woke up and they send patient to radiotherapy department and now start this adjuvant radiotherapy. To highlight this problem, I just refer this paper from Ang, and it is not a new paper. It was there in 2001, and they very, very clearly say कि अगर आपका patient high risk है, and obviously post-op RT is सबसे ज़्यादा important in high risk patients, then please finish your overall treatment, that is surgery plus adjuvant radiotherapy. Please finish it less than 11 weeks. This is the LRC, local regional control. This is the survival. This is the actual LRC and overall survival in high risk patient as a function of duration of the overall package. Surgery plus adjuvant RT. This is the package. Try to finish it less than 11 weeks. हमेशा हम कहते हैं ना पेशेंट को, अरे आपका सर्जरी हो गया, now you have to take radiation, start radiation in 6 weeks, 8 weeks, 4 weeks. But remember, it is the total package time which is important, and you have to continuously raise this issue with your surgeons. Then please send patient on time. Okay, this is not related to hypopharynx larynx, but this is for the overall head and neck. But I just want to highlight this point. Please do adjuvant treatments on time. Otherwise, आपको जो benefit लगता है कि LRC will decrease with your adjuvant, that is not the actual thing. And it will not, adjuvant treatment is not helping to decrease LRC that much that you are expecting. Okay, that's all. So we have seen from the Europe, and this is from the ESCO. This was in 2018, and this is also a nice guideline. I mean, residents can refer it further. This is a very nice practical guideline, and this is around 20 pages. You can flip it. I mean, and I have just take snapshots further to probably highlight the things, or maybe little bit difference from the European philosophy versus the American philosophy. So this is the first step, important snapshot, and I have marked here 1 to 5. So 1 is same, T1, T2 laryngeal cancers, intent to preserve the larynx, either with radiation or with the endoscopic resections, laser surgeries, partial surgeries, functional preserving surgeries, okay, and similar outcome. So no confusion. Second is locally advanced disease. So again, same, try to do organ preservation, combine chemotherapy and radiotherapy. So they are very clear. They just prefer CRT. They put induction little lower, a little on the lower end towards the level 2 evidence. That is the difference. But CRT is yes, definitely. अच्छा, important is अगर patient आपका fit नहीं है for chemotherapy, then please don't say in exam. I mean, I have also done the same mistake, and nowadays I'm seeing ki, my juniors are doing the same mistakes. If we say ki this is a locally advanced disease and patient is somehow not fit for the cisplatin, patient has renal failure, renal disease, CKD, whatever, then what you will do? They directly say, okay, if we can't do CRT, then go for surgery. No, there is another third option, that is RT alone. Okay. So हमने फॉरेस्ट ईयर में देखा था, फॉरेस्ट ईयर के जो एनईजीएम 2003 था पेपर, कि आपका जो लैरिंक्स प्रिजर्वेशन था दैट वाज 88% इन सीआरटी, ओके, विद इंडक्शन इट वाज अराउंड 75 or 78 probably, and with RT it was 70. So don't forget this 70. It's not zero. कि जब तक कंकरेंट कीमो ऐड नहीं होगा तब तक रेडिएशन कुछ नहीं करेगा. प्लीज दिमाग, प्लीज डोंट फॉरगेट इट इन द एग्जाम आल्सो, कि आरटी इज द मेन थिंग, कंकरेंट कीमो, इंडक्शन कीमो, दीज आर जस्ट एडिशनल सपोर्ट. ओके, अगर मुझे आई वांट टू कोट मैकेंसी हियर, कि मैकेंसी का रिजल्ट क्या है? इट वाज इंक्रीज इन ओवरऑल सर्वाइवल अराउंड 6%. तो 0 से 6 थोड़ा ही है. आरटी का एडवांटेज इज ऑलरेडी अराउंड 60-70. इस पे एडिशनल एडवांटेज, दिस इज एडिशनल थिंग. तो दैट्स व्हाई आई जस्ट वांट टू हाईलाइट, प्लीज डोंट फॉरगेट ओनली आरटी का ऑप्शन. ओके, क्या होगा अगर आप सीआरटी करते हैं, 88% पेशेंट में लैरिंक्स प्रिजर्व करेंगे और बाकी में आप सैल्वेज सर्जरी करेंगे. अगर आप ओनली आरटी करते हैं, देन यू विल प्रिजर्व द लैरिंक्स इन ओनली 70. 88 से 70 कम हो गया, but still 70 में करेंगे, and in 30% you need salvage surgery. I hope I am clear on this. Okay, third important point, for selected patient with extensive T3, I already said it, that extensive T3 मतलब unfavorable T3, क्योंकि पूरी कहानी तो T3 में है. Unfavorable T3 and large T4A, or poor treatment laryngeal function, repetition. Okay, so unfavorable T3, large T4s, and poor function. No organ preservation, go for total laryngectomy. Okay, clear cut survival advantage, better survival rates. Okay, fourth point is about N+ disease. I already said you need radiological imaging response. You have to go for PET at 12 weeks. So this is no more needed here again. Should undergo, fifth point is should undergo a pre-treatment baseline assessment of voice and swallowing. I already highlighted in the workup slide, जो second part I have shown, कि CT chest उसमें recommended है guideline में, but second part is assessment of functions, voice and swallowing. You can do it by the VFG. VFG is what? It is modified type of barium swallow. वीडियो फ्लोरो गाइडेड स्कोपी ऑफ swallowing functioning, कि अगर उसमें ट्रिकल कर रहा है, एस्पिरेशन दिख रहा है, then it is a poor function. Okay, don't try to preserve the larynx. So this is very important point here. I'm sorry. This is the repetition कि you have to see the factors that may influence the selection of treatment modality. और ये मैंने अपना पॉइंट रखा था फिजियोपैथो में भी कि आपको ट्रीटमेंट मॉडलिटी सेलेक्ट करते हुए यू हैव टू सी द वेरियस अदर फैक्टर्स देन द TNM, extent volume of tumor, vocal cord mobility, that is again the function thing, involvement of anterior commissure, lymph node positivity, and age, occupation ka, if I have to give one example, I just read it from the National Cancer Grid कि if suppose your patient is having the early disease, T1, T2 disease of larynx, and patient is singer, then what you will choose? Laser surgeries, partial surgeries, or RT? So whatever evidence says कि voice quality is better with RT, so you can choose that. But if your patient is daily wager, रोज कमाता है, रोज खाता है, then please don't choose 2 months radiation treatment and just finish it in one go. That is the partial surgery, laser surgery, that kind of thing. Voice quality, swallowing function, patient preference, and compliance. So I get it is already 8:50. I will finish faster. This is the repetition, and this is again the repetition from the same guideline. T1, T2 larynx, no need to address neck. I am just skipping it again. I'm just skipping it. And now I just come to the impression from India, but I guess there is no time and I have to rush through. So this is the NCG guideline, National Cancer Guideline. This is free. This is available on the internet. You can download it and please go through it. This is a very nice guideline, and there is nothing new, nothing additional. What till now we just saw from the ESMO guidelines or from the ESCO guidelines. So I will not go through it. And now directly we move towards the field borders. Is it okay, Dr. Surbhi? Ma'am?
Yeah, Dr. Mrinalini, continue.
Okay, okay. Okay, so now we just move towards the actual radiotherapy field borders or segmentation. Probably you are waiting, I mean, for that. I mean, residents must be like that ki kab aayega. So first we will deal with 2D fields, and I will do it in 2 parts: T1, T2 larynx, T3, T4. It is very important for exam point also. And then we will go for 3D plannings. So again I'm mentioning that T1 and T2 ke liye it is less than 5% propensity for nodes, so no need of nodal radiation. That's why we choose a very chota field, that is 4 by 5 centimeter probably and 5 centimeter, and field borders are, this is the thyroid notch and this is the cricoid cartilage. So we just cut through the cricoid cartilage. This is our caudal border, this is cranial border. Posteriorly, as we don't need to treat the neck, so we can keep it on the anterior, the anterior border of this, anterior border of the spine. Anterior border is very important. Okay. Why I'm saying it, I will show in the subsequent slides. So I will show directly into the field border. So this is the actual field. This is C1, 2, 3, C4, C5 and mid C6. तो आपका field इतना बड़ा ही होगा T1, T2 larynx पे. और what I mentioned here कि T1 में you can go through this cricoid, but in T2 you have to cover the whole cricoid. Don't forget it. You have to cover the whole cricoid in T2. Okay. So this is the field border of T1, T2, and this is the parallel opposed from the right and left lateral end. And I am just highlighting it from because if we are just giving parallel opposed beams with that field border, what we have seen in the earlier slide, we can appreciate here that there is a hot spot. Okay, ये जो 107 का एक वॉल्यूम है, दिस इज द हॉट स्पॉट. I mean, it is obviously more than 100%. This purple is 100%, so we are very much okay, because now, if I mean, we can appreciate here, na, this is the cricoid cartilage. It is very beautifully covered in it. Okay, and this yellow is 95. Okay, so 95 may our anatomical compartment is safely treated, but problem is high hotspot. तो हम क्या करेंगे hotspot के लिए? We use 15 degree wedges. Cobalt पे भी use करते हैं. तो ये hotspot volume will reduce. Okay, that is one point in the planning. Second point is if our anterior commissure is involved. Okay, and anterior commissure and spaces, pre-epiglottic space, paraglottic space, as I already mentioned, these are towards poor prognosis. So अगर हमारा anterior commissure must be somewhere here, and anterior commissure is directly in the contact of thyroid cartilage, and there is some ligament, I forget the name, or something. So ये area हमें anterior commissure का involved है. Then we have to cover involved side का vocal cord, anterior commissure, and the opposite side का भी anterior part of vocal cord. तो इसको अगर हमें safely we have to treat it. Then your parallel opposed field with wedges, these may miss this part, because if we can see here, this is only 50%, and patient can move daily up and down. So what we can do, we can use this bolus anterior side पे. Is there any problem? Hello, is there any problem? Should I continue?
No, you should continue.
Okay, thank you, ma'am. So if we use this bolus on the anterior side of neck, then we can see कि जो आपका 95% or 100% volume is pushing little bit anterior side. So now our patient is safe. It is like that. This is our letter. So what we have to do? Should we take the same size of envelope? No. Our letter can tear. So what we can do? This is our letter. We can take a little bigger envelope so that our letter is very much safely delivered to wherever we want. So this is envelope. So this is your PTV kind of thing. That's why we put bolus and we just extend this safe margin here. This thing I have taken from the book, Bantel book. You can take that book. That is free. That is also available on the internet. Just go through it. So anterior commissure mein you have to remember about the anterior bolus ka story. So now we have finished the T1, T2 larynx. Now we move towards the T3, T4 larynx and pharynx patients. More or less the same fields that we have to move. We have to treat here neck and the whole anatomical compartment, nodal levels, and we have to cover nodes up to the base of skull. So our cranial border is towards the base of skull. Posterior is to covering the level 5 lymph nodes. So we can just leave 1.5 or 1 centimeter strip over the neck and just place our posterior border. Anterior border in T1, T2 larynx में what we have done, we have taken extra. This is called flash. कि आपको skin पे 1 centimeter आगे जाना है to cover this point with the movements. But here should not. We don't need here, but we have to take this anterior border up to the cranial line, and we can use the shield here. These are MLCs, but even on cobalt you can use the corner shields. These are corner shields because this area doesn't need treatment, and this area has minor salivary glands on the palate. So use shields and prevent this area. Okay. Probably it is more clear here that shrinking field technique, what we do, that is phase 1, phase 2, and phase 3. So what is phase 1? Phase 1 is 44 in 22. Phase 2 is additional 6 in 3, and this is spinal cord off. Phase 3 is additional 20 gray to make it 70. It is just boost to the gross disease. ये gross disease आपकी primary भी है, and this gross disease can be the nodal also. Okay, this is the concept in whole head and neck radiotherapy about the shrinking field technique. And this is the diagram I again took from the Paris only, the older version. This is your phase 1 field, because you want to cover up to the base of skull, all the nodal things. And here you have to cover the whole anatomical compartment. This is the posterior neck nodes, and this is the shielding area. In phase 2, you have to do the cord off. I hope this is the clear. In phase 3, that is the remaining boost, you have to further lower down the cranial border. Okay, because आपका जो uninvolved node है उसके लिए 50 is sufficient. Now you can just give 70 grade to this field. Okay, this is your primary disease or plus minus your nodal disease. So this is a parallel opposed field, and with this parallel opposed field we have to give the LAN field. LAN is lower anterior neck, because इसके नीचे तो shoulder आ जाएगा. So you can't give parallel opposed through the shoulder. Please don't do parallel opposed through the shoulder. Okay, otherwise आपका shoulder is getting all the dose, and in the center point you are getting nothing, but you think in your mind that you are giving the dose to SCF. It's like double nuksan. Okay, LAN I will clear more in the next picture. Okay, so this is our LAN field. We already know it कि यहाँ पे junction बनाना है आपको parallel opposed fields के साथ. तो parallel opposed divergence beam है, यहाँ जाएंगी, यहाँ जाने पे you will get the hyperdose. So what you will do, आप यहाँ पे एक shield use करते हैं. This shield is like this. This is 1 centimeter, 3 centimeter. इसका जो depth होगा, thickness जो होगी, that is also 3. And we are using it for the, because LAN में हम कैसे करते हैं? We use LAN like this. Clavicle से 1 centimeter नीचे लगाना है, 2/3 cover करना है. That's मतलब everybody knows, I know. But ये जो है, हम इसको half beam block करते हैं कि इतना बड़ा LAN field खोला, इसको हमने half beam block कर दिया. That's fine. तो आपका block करने पे this is going directly, fine. But जो divergent beams ऊपर की आ रही हैं, parallel opposite, उनका क्या करेंगे? तो ये जो extra dose है, इसके लिए LAN field में we use the central shielding. That is the 1 centimeter, and that is for the spinal cord, क्योंकि यहाँ पे आपके नीचे spinal cord है. Okay, तो इसको overdose से रोकने के लिए you have to use the central shield. Another important point in the tracheostomy patients, post-op patients, whenever you are giving radiation to these patients, please use this kind of plastic tubes just to make the good dose coverage around the stomacal lining. ये आपका tracheostomy का lining है. You need proper doses here because this is prone for recurrence. तो कैसे होगा? This is air ना, तो यहाँ पे तो डोज आएगा नहीं फिर कॉर्नर्स पे. तो what you will do, you will make a bolus, but पूरा bolus तो बना नहीं सकते. Patient का breathing is stopped. So stoma में you can put the plastic tube जिसका open होगा and यहाँ पे, and you can give this rim को good coverage to reduce the recurrences or to stop the recurrences. So I guess I have completed about the 2D plans, and now we move towards the 3D plans. But before going towards 3D, I just want to share 2 slides about the nodal propensity. T1, T2 larynx, already we said it is less than 5, so no need to do neck treatments. But in supraglottic larynx, 2, 3, 4, you have to treat. And this is again from the Paris. This is the Linderberg series. This is for every site in head and neck. Please go through these. These are very helpful. This is the contralateral, opposite side. इसीलिए ipsilateral में you will see in segmentation. In ipsilateral we have to cover this whole. In contralateral we will cover little less. So this is supraglottic, and this is for the hypopharynx. We always know this is 148. I mean, just see the figure. This 148. So in exam, whenever we get this is a case of secondary neck, primary unknown, and SCC, then our first differential diagnosis is pharyngeal malignancy. Whether it is nasopharynx, 90% propensity, whether it is hypopharynx, that is 80% propensity for neck node, or whether it is oropharynx, that is around 60%. Okay, that's why I put this slide here to show, I mean, how much important it is to treat the neck in these patients. Okay, so towards 3D, what is important? potentially unseen disease, that is CTV. That is the whole business about the segmentation. Anatomical compartment is again important. So this is the guideline in 2019 in Green Journal paper, and this is the update, because first one comes into the 2003, then comes into 2006, and then it is the update comes into 2019. किस पेशेंट में किस स्टेज पे किस साइट पे आपको कौन सा नोट ट्रीट करना है. प्लीज गो थ्रू इट and I will just take the snapshot, important one. So first, it is about the hypopharyngeal cancer. Dr. Surbi, I know it is very late. Please ask me to stop anywhere.
Yeah, you continue. Yeah, continue.
Okay, thank you so much. Really, thank you. So for hypopharyngeal, it is very, very easy to understand. Understand hoga, you can, I mean, it is very easy to remember also. Don't go with those numbers, otherwise yaad nahi hoga. So please remember 2, 3, 4 में अभी हमने देखा था propensity is much. तो 2, 3, 4 that is a jugular, है ना, deep jugular. Treat करना ही है whatever is the stage. Remember we are talking about hypopharynx T1 to T4 and larynx T3 to T4 because T1 T2 का business we have already finished. So 2, 3, 4A. अब 4 में थोड़ा सा एक twist है. 4 को we know कि 4A और 4B में हमने divide किया है. 4B is equal to SCF, okay, and 4A is deep jugular का lower most part. तो 4B को भूल जाएंगे. It is about 4A. तो 2, 3, 4A हमें सब में ही ट्रीट करना है, इप्सिलेटरल और कॉन्ट्रालेटरल, क्योंकि प्रोपेंसिटी बहुत ज्यादा है हाइपोफैरिंक्स में. 7th A is retropharyngeal. 7th B is retrostyloid. Okay, retrostyloid क्या है? ये जो हम लेवल 2 बनाते हैं, इसी का जो ऊपर एक्सटेंशन अगर हम कर दें up to the base of skull, तो it is the retrostyloid, but name is 7th B. Okay, तो थोड़ा सा इधर गड़बड़ है कि ये लेवल 2 है, ये 7th B है, पर try to remember it. Okay, so 2, 3, 4A हमें करना है. 7A हमें करना है, दैट इज द रिट्रोफेरेंजियल लिम्फ नोड. कब करना है? जब पोस्टीरियर फेरेंजियल वॉल का ट्यूमर है. तो बहुत ही आसान है याद रखना. व्हेनेवर इट इज द पोस्टीरियर फेरेंजियल वॉल, तो रिट्रोफेरेंजियल लिम्फ नोड कहाँ है? पोस्टीरियर फेरेंजियल वॉल की बगल में तो पड़ी है नीचे. तो यू हैव टू ट्रीट द रिट्रोफेरेंजियल लिम्फ नोड ग्रुप, दैट इज 7th A. रिमेंबर इट. ओके, अनदर इंपॉर्टेंट थिंग इज कि लेवल 6 हमें एडिशनली कहाँ ट्रीट करना है. तो लेवल 6 कहाँ होता है आपका? लेवल 6 इज प्रीट्रैकियल, प्रीलैरिंजियल, पैरालैरिंजियल. ओके, तो लेवल 6 आपको ट्रीट करना है जब पायरिफॉर्म साइनस है, पोस्ट क्रिकोइड एरिया है, इसोफेगियल एक्सटेंशन है, सब ग्लोटिस है, देन यू हैव टू ट्रीट द लेवल 6 आल्सो एडिशनली. ओके, तो दिस इज ऑल फॉर N0. इफ पेशेंट इज N+, तो इट विल रिमेन सेम. 2 करना है, 3 करना है, 4A करना है. ऑलरेडी वी हैव डन लेवल 6, ऑलरेडी वी हैव डन. नाउ वी हैव टू ऐड 5th A and 5th B, दैट इज द पोस्टीरियर नेक. बढ़ते हैं ना, दिस इज 5th A, दिस इज 5th B. ये दोनों आपको लेना है व्हेन इट इज द नोड पॉजिटिव नेक. ओके, N2C इज सेम, N3 इज सेम, कोई एडिशनल नहीं. 1B एडिशनली आपको N+ में लेना है. तो एक स्टेशन ऊपर बढ़ जाइए. अगर N+ है दैट इज 1B. एक स्टेशन पीछे बढ़ जाइए, दैट इज 5th A and 5th B. और आपको लेवल 7A तो देना ही है. आई होप आई एम लिटिल बिट तो क्लियर हो ही गया होगा यहाँ पे. सो नाउ टुवर्ड्स द लैरिंजियल कैंसर. तो फर्स्ट इंपॉर्टेंट थिंग, इसमें हमें लेवल 7A दैट इज रिट्रोफेरेंजियल, उसको ट्रीट नहीं करना बिकॉज दिस इज नॉट हाइपोफैरिंक्स, दिस इज लैरिंक्स. 2, 3, 4A वी हैव टू डू. 6 वी हैव टू डू बिकॉज इसमें तो सबग्लोटिस की कहानी है. For N0, N1, N2 पेशेंट्स में अगेन 2, 3, 4. When it is there, then we have to move पीछे, that is 5A, 5B. तो N+ में we have to add 5A and 5. N3 जैसे ही नोड बड़ा होगा, then go 1 station up, 1B. तो this is just a philosophy. 2, 3, 4 you have to treat. If it is N+, then move up, move down, move posterior and move down also. That is level 4B also you have to treat. अच्छा, You have to move up. You have to treat 1B, and you have to move little up further for the base of skull. That is 7th B. That is retrostyloid. This is the retrostyloid. So N3 में you have to treat retrostyloid also, 1B also, और N2B तक आपको 5B. तो 2, 3, 4 is common, and 5, 1B, 7B are in N+. Okay, ये तो मैंने उधर ही बताया. So okay, ठीक है. No need to repeat it here. Okay, so now we have finished about the neck nodes, how we have to when we have to treat which level. Okay, now we come to the CTV, that is the primary CTV, and this is again the okay, abhi to ye publish ho gaya hoga, I have taken it that time. This is about the CTVP, I mean primary CTV, about the all disease. By again I just take for hypopharynx and larynx. You can go to, I mean, you have to go through it if you really want to practice the segmentation. So just snapshots, and very important thing, please remember philosophy of 5 by 5, and this is for same from Europe, in Europe also, in the I mean in the USA also. 5 is, this is your gross disease, आपने बना लिया, then you have to go 5 millimeter, and this is your CTV1, that is the highest dose हमें जिसको देना है 70. Then again make a rim. This is the CTV2. Okay, जिसको हमें थोड़ा कम डोज देना है 66. So this is not rocket science. सबसे ज्यादा डिजीज यहाँ धीरे धीरे सेल कम होती जाएंगी, तो you need a कम डोज on the periphery. Okay, so this is a 5+5 philosophy for every site, for every stage. Okay, additional thing, you have to make it, you have to cut it from the air cavity. Suppose this is air cavity, though, and I will cut my CTV like this. Suppose this is bone, then I will cut my bone like this. But important thing, if I feel there is a space, there is a chances कि I can't see with my eyes, I can't see with images, I can't see even by scopies, then I will cover little extra. So guidelines are not holistic books. You can modify your guidelines according to your scenario, according to your facilities at your center, according to your learning curves and everything. So this is all is given in this guideline, but basic philosophy is 5+5. And important thing is after CT MRI on which you have to delineate, please don't make it to don't do delineation or segmentation on your older CT scan. Okay, today is 1st April. I have taken the RTP. Now I will treat this patient in May. Please don't do that. उसमें आप जो segmentation करेंगे, your gross disease will go even beyond your PTV. Don't do that. Your planning CT scan must be in the less than 3 or 4 weeks ka. Otherwise you are treating something and disease is something. Okay, so 10 millimeter ka we understood, it is 5+5, but for hypopharynx there is a twist. And why this is this? Because we have seen in the anatomical diagram, this pharyngeal wall is a continuous structure. Oropharynx की boundary भी nasopharynx की boundary भी बनाती है, oropharynx की boundary भी बनाती है, hypopharynx की. This is a continuous structure. Okay, it is like somehow esophagus type. So इसमें 5+5 is not sufficient. What we have to do? We have to do cranially and caudally more. Okay, we have to take 2 to 3 centimeter. And remember, I am not talking about at my center, but it is from the Western data. For the hypopharynx, you have to treat more, 2 to 3 centimeter extra here and 2 to 3 here. Okay, so no more 5+5 craniocaudal side mein, it is more because it is a continuous structure and very rich in the networks, this submucosal network. So this is the same, just 4 points I want to highlight about the segmentation. When you are going to start it, you are practicing it, you want to master it, please remember 5+5, then hypopharynx ki kahani more, 2 to 3 centimeter air cavity se crop karna, and you have to adapt for the complex head and neck anatomy. Okay, so like I already mentioned कि कहीं space लग रहा है या आपको कहीं doubt लग रहा है कि anatomy थोड़ी सी twist है, तो please don't say no, guideline says 5+5, no more guideline, please adopt please modify your guidelines. Okay, you don't have facility of radiologists, you don't have facility ki your radiologist will come and sit with you and help you to recognize. So please modify according to your things, your learning curves. Okay, barriers, we have to respect the barriers, that is the bone and tight fascia. And as adaptation to take into account the experience, obviously I already mentioned, this is about your learning curves. One thing is anatomical relationship. Segmentation karte samay, segmentation is not drawing. You have to know the anatomy, you must know the stage, and then over it you have to do the segmentation. So your base must be clear. So this is all about from this guideline for the primary tumor CTV from the Green Journal for the larynx. And this is, I just want to say ki what is the understanding कि अगर आपका disease जहाँ पे है, you have to go one step more. It is like that. I will clear it. कि suppose we say in T2. In T2, we have to cover the paraglottic space, anterior commissure, anterior part of the contralateral vocal cord for tumor extending to the anterior commissure. This I already said. कि अगर आपका एक साइड ट्यूमर है, एंटीरियर कमिश्चर जा रहा है, then another side का vocal cord you have to cover on the anterior side. Why? Because this is a continuous thing. Tumor can directly continuously go like this. Okay. And another highlight thing is in T3. In T3 mein what I said कि T3 mein inner cortex is involved. In T4 mein, it is up to the outer cortex. Okay. So in T3, when there is involvement of inner cortex, then you have to include part of the thyroid cartilage. Okay. You have to remember it. Okay. And so when you include the thyroid cartilage in CTV P1, that is primary one, then you will further go 5 millimeter in the cartilage for the lower doses. Okay. Ditto for the supraglottic larynx and ditto for the hypopharynx. So this is the hypopharynx, and I just take this snapshot to again highlight the thing more craniocaudal, that is the 2 centimeter around more extension into the craniocaudal side. Or I don't think this is easy to remember. Even for me, this is not easy to remember. It's better to keep it on the side and then start segmentation, and slowly you will learn and then you will remember it. So just go through it. Okay. In hypopharynx, important thing I mentioned in T3, it is the upper cervical esophagus is important. So if you are making CTV in your hypopharynx ka T3 stage ka tumor, then don't say कि I will not take esophagus. You have to may extend into the upper cervical esophagus. Okay, otherwise you are leaving the way for recurrences. Okay, and then don't blame the techniques, because you must have that knowledge. You must have the understanding of these things, especially towards the spread of tumor, so that you can cover it and you can make a confident CTV. Okay, so that much important about the CTV. The same in the opposite direction. Suppose it is going to cranially side, then your CTV may extend into the oropharynx. Okay, so that's all for the segmentation, and this is probably my last slide to just represent the relative survival, that is worse in the hypopharynx in spite of doing everything, and it is best in glottic. Okay. So, so this is my last slide, Dr. Surbhi. If any question, anything, or any comment, I will happy to take that. Or probably if I left something, then sir can add or you can add anything. Thank you from my side.
Yeah, first of all, thank you so much, Dr. Mrinalini. You have covered so much, and each and every aspect of practical things you have covered. There is no question